Thank you, Cindy. I'm going to invite up Yvonne Goldsberry and Deb Fournier to engage in a discussion, and we already have a question right off the bat.
Sure.
Yvonne is the gatekeeper for the question.
Oh, absolutely. And we were going to do a little preamble, but given the time, we're going to skip that and go straight to questions because I know there are some. Go ahead.
Thank you. So the idea of a work requirement, I kind of understand who they think would participate in the expansion population. But when I see it applied to the traditional population, are we really thinking about sending children and nursing home patients and people with disabilities to work? Am I reading that correctly?
I don't know what the expectation is. There's no requirement as to who it gets imposed on, but we do have some states that are thinking about work requirements who have not done an expansion. And so one does wonder who's going to take up the work requirement. The other thing to think about in terms of issues around work requirement and new conditions of eligibility, one of the things that has happened in the Medicaid program across the country is a simplification of the program and making it more like health insurance and less a welfare program. And it's, it's value-based purchasing. It's all the things you've been talking about all day. And if you did a work requirement in the program, just your application process, your administrative responsibilities would change dramatically. And it's not just, do we have a work requirement or do we not, and do we have a population that's appropriate for a work requirement, but it also really changes a lot about how people are processed through the system, what Deb's agency does for a business, and churning, which I think really raises an issue around the value-based purchasing. People will be in and out as they comply or don't comply with those requirements.
Deb, do you want to add to that?
No, the department started to grapple with the operational components of what would it look like to impose a TANF-like work requirement on just the expansion population. And it is overwhelming because it takes us out of sort of a nice annual redetermination period, looking at financial information and family construct, and puts us into monitoring a whole other component of people's lives that is certainly not Medicaid's forte.
I will say a couple, and I'll stop here, but a couple of states that thought about a work requirement and then didn't get approval to do that have done referrals to work programs, right? So there are ways in which you can help connect people to work and to job training services as they apply and give them the option to go forward.
Right, and so to put it on a more positive spin, I think the department is very interested in what is keeping folks out of employment who are in our expansion population. We don't know much about that. We know that the vast majority of people who identify themselves as not, or who we identify as not having wages as income, have been separated from employment or not involved in employment for more than a year. And I think in order to make any kind of productive progress in helping people towards full employment or fuller employment, we would need to know what's keeping them at home. Are they caretakers, parents? Is part of their need for health insurance that they are receiving Medicaid for the reason that's keeping them out of the workforce? Do they have dental issues? Do they have mobility issues? Do they have transportation barriers? It's probably, in addition to education and training, right? It's probably any number of those things, but that would be a great place to start to find out what is actually going on with respect to people's employment profiles and what their challenges are with respect to work. And I mean specifically for adults. The idea that we would apply work requirements to our kids and our pregnant women and our elders and our folks with disabilities has never, Cindy, as you know, been part of the local conversation, at least not to my knowledge. But it does make one wonder what the boundaries of it are.
So why don't we go up to Doug and just say who you are, because I think we're still on the web.
Talk up to the microphone. Yeah. I'm Doug Manatt from AARP. So my question is, because that's not clear to me from following this, a lot of our long-term care funding in this state comes from Medicaid enhancement taxes. What would this act do to that funding on an ongoing basis?
Nothing at the moment. So the House bill does not make any changes in state rules on provider taxes, so you could still rely on assessments, provider assessments, to raise your non-federal share. There was some rumor that the president's budget included some limitation on provider taxes, but it's unclear whether that rumor was wrong or just the detail in the budget was such that nobody was able to see it. But the bill, it doesn't change how you raise the dollars. That might come along, but not at the moment.
Do we want to go over to Steve Onen?
Steve Onen with the Hospital Association. Bill may not change how they can raise money with provider assessments, but I can be certain to share that we would have a very different perspective on the Medicaid enhancement tax if we were subject to a per capita cap. So while it may not change from the federal perspective, we would have a very different view of that.
Did you have another question at all? Or want to stay on the MET topic, Kevin, or?
Kevin, so two quick questions. One, why do you have an Office of the Actuary if you don't use them for trend? And two, what, if any, impact would there be of high-risk pools or some type of that notion that's been kicked around?
Yeah, it's a good question. Well, I don't know. Usually the president's budget relies on the OACT, on the Office of the Actuary's projections. Supposedly, again, it's a little opaque. This year they didn't. CBO always comes up with its own, somewhat informed by OACT, but it comes up with its own. So that's not unusual that there be different baselines, but they're not using the OACT trend. If they used the OACT trend rate, it would be much higher than the CPI measures that are in place. And they're not using it because they really are intentionally trying to set a rate that is lower than what's projected, right? So so that there's in fact lower federal dollars. The high-risk pools. So I do think there are other provisions in the law, which I did in the bill, which I didn't discuss, having to do with the marketplace. There would be changes in the subsidies. They would be thinner and age-rated in bigger age rating that is allowed now under the ACA, and thinner amount of the subsidies, and they would go down to 0% of the poverty line. So right now you cannot get a subsidy below 100%. So it is possible that in a state that didn't expand or in a state that did expand and didn't maintain its expansion under the bill, that people could potentially access those subsidies and buy coverage on the marketplace. But it would be less deep a subsidy than the ones available today. So there's questions about both affordability and scope of benefits.
Cindy, how big is that high-risk pool funding? Do you remember?
No, I don't.
I want
Well, it's like $8 billion.
Right, it's $8 billion. So New Hampshire Medicaid is a $2 billion going concern, and we only cover 187,000 people.
Yeah,
so
that's
$8 billion
different than-
won't
right.
get you very far with respect to covering people with pre-existing conditions all across the country.
Go up to Tess.
Thank you. So can you help me understand a little
Stand
bit?
up, it's hard to shoot you.
Tess, can you just let folks know who you are?
Oh, I'm Tess Kinning, the CEO of Bi-State Primary Care Association, representing the health centers in Vermont and New Hampshire. So I have a lot of observations, but I'm going to just stick with one right now. So under the options for the states in a waiver, you can change the essential health benefits. So there's you can waive the essential health benefits, and in that waiving of the essential health, some of those essential health benefits, you lose your pre-existing condition and your lifetime benefits for that. Can you talk a little bit about that?
That's in the well, I should have mentioned there were a couple other, obviously there's other things having to do with Medicaid in the bill that I didn't mention. One is that the essential health benefit floor for Medicaid expansion would go away, and states would have an ability to change the benefit level. I should also mention that there'd be a prohibition against, for 1 year anyway, using any federal dollars to provide payments to for family planning for any provider that also provides abortion services. The provision, though, I think you're talking about is in the private individual marketplace. That a state could, they use the word waiver, but it's different than the Medicaid waiver. A state could waive out of different of the beneficiary consumer protections in the Affordable Care Act, like pre-existing conditions, and that's the one that's gotten the most amount of attention, as well as potentially lifetime or annual limits on benefits. And then they would get the ability to have, they would get the waiver if they showed that they had a high-risk pool and some other mechanism to be able to address people's needs who might be affected. But as Deb pointed out, the funding for the high-risk pool is probably not enough to sustain that need, to address that need. Unclear how many states would go that route. A couple have, raised their hands and said they're interested in. Interesting that the Congressional Budget Office thought that quite a few states would actually go that route.
And ending EHB for Medicaid would end our requirement to offer substance use disorder and mental health treatment for our expansion adults. It doesn't mean the state would necessarily take that step, but it would no longer be something that we had to do in order to maintain the eligibility group.
So the second question would be the added Trump in his
In the
budget, that he's taking another 600 and some billion dollars out of Medicaid, and how does that sort of factor into the 834 billion that we'd already lose?
Well, that's a really good question, and one that I can only give you a convoluted answer. First of all, going back to baseline, it's all about baseline. The president's budget uses a different baseline than the Congressional Budget Office's baseline. I'm not quite sure what baseline it's using, but it's different. So we think it's probably not correct to add the 830 with the 620. I think probably, it's probably the 830 is probably worth about 600 or so in the baseline that the president's budget uses, so it's probably more like 1.25 together as opposed to 1.4, if that makes a difference. So I just want to say that I don't think you can quite add the two up. It's very unclear, and they're going to be testifying when they come back from recess. Secretary Price will be testifying about the budget. There was some statements by the head of the Office of Management and Budget about the Medicaid provisions in the budget, and it was pretty unclear. The understanding is that it further restricted the trend rate. It brought down, so got some of those savings through a trend rate reduction. And as I said in answer to the other question, there were rumors that the president's budget was also going to constrain provider assessments and provider taxes, and so that might have contributed to it. But they really didn't identify the Medicaid cuts in the budget documents. You can pull out the dollars, but you really can't pull out the policies.
So why don't we come down to Tim? Did you have a question?
I'm all set, thanks.
Jean?
So you both know a lot about New Hampshire's Medicaid budget for various reasons, and I'm curious, I'm struck with trying to understand, even in the most generous scenario that you presented, Cindy, where would that money come from? How would we cut that much out of our Medicaid budget in this state right now? And Deb, I think the 19-month tenure for Medicaid.
I know, I was just about to start looking at my calendar. Isn't that today, Jeannie? So that I don't have to, so when I think about this, and sometimes I do lay awake at night and think about it, I don't have any easy answers at all. I don't know all of what the ability would be for the state to change the way eligibility and enrollment works right now. So the tools at the state's discretion currently are unchanged. There are mandatory services and mandatory populations and optional services and optional populations. Those are very, very loaded and difficult choices. Long-term supports and services in any given year is about Let's just talk about some of the waivers, not all of long-term care together. It's $250 million. Who's gonna make that choice? I am the executive branch,
So
right?
Steve, okay.
So there is a question of upfront advocating for how horrific the risk the state's gonna face, and then there is gonna come a time when we're gonna have to figure out how to manage it. And in true New Hampshire spirit, there certainly seems to be a couple ways of manipulating this. One is we have very high long-term care per enrollee costs, largely driven by nursing home expenses. So to the extent that we have this new incentive to drive down those long-term care costs, theoretically, we win. You look at Vermont, Maine, they're at 8,000 per, we're at 16. So that's one game. The other game is this question of the trend. We grew in that 2000 to 2011 period, that is the last data that we have from CMS, at less than the medical inflation rate.
Right.
Right.
And so, you know, how do we gain, as a group of folks that want to protect a set of resources, how do we gain this question of base rate trend going forward? Because we have demonstrated capacity to manage underneath what is the existing inflation rate going through the house.
We have, but none of that data currently reflects the initiation of Medicaid managed care or the onset of the expansion or the DSRIP. And I think every Medicaid director, well, I can't speak for my other Medicaid directors. I think that there are many Medicaid directors who would say a per capita cap, I can get my head around that, right? We can probably manage to that. But for whatever the unexpected thing is, the next hepatitis C drug that comes out that costs $500,000 a pop, or as I said earlier, the next great societal event that drives particularly sick people into New Hampshire Medicaid or any Medicaid program. So, Jeannie, I would go back and I would say, you know, optional services, prescription drugs, community mental health center services. All 4 of my 1915C waivers are technically optional, right? That and I don't want to. Well, I'm being a little dramatic. But I don't want to overstate. That is the value of the level of size of choices that Cindy's information seems to beg, right? And I completely agree with Steve that it's all about the parameters that you're working under. So what is the pot of money? What is the base? And how big is that trend rate? Because depending on that answer, right, you might have a little more room.
Only if things continue to change in a predictable way, which
Right.
they will not.
So we're gonna come back over here, because you've been waiting, and in all fairness, you had an opportunity to ask a question before, which is why I went over here. So, go
I'm
right
not
ahead.
upset, I just wanted to ask a question. When we originally worked on the bill, as Cindy will remember, we thought it would take an act of Congress to change what we called circuit breakers. And those circuit breakers would happen in 2020 now with an act of Congress that we're actually looking at. So you showed a slide that looked at 2026 implications, but I think more realistically, if we're looking at a sizable increase in the state burden in 2020 because of an act of Congress, we're going to see the end of Medicaid expansion as we know it in 2020. Can you look at that slide and tell us what, just guesstimate, what that cost to the state would be in terms of lost federal dollars?
Yeah, that was one of the options that was on the slide. So if you assume that you maintained the expansion, but only for the grandfathered individuals.
I'm sorry to interrupt. This is an immediate circuit breaker that requires reauthorization of all Medicaid expansion if there's a change in the federal.
And I'm trying to respond to that situation. There would not be a change in the match rate for the grandfathered people. So so our assumption and laid out in one of the slides, and I think consistent with what you're saying as to what the what the New Hampshire legislature intent was, is that you would not you would not keep the full expansion that required going to the regular match rate, but you might keep just the grandfathered group, which gets smaller over time. And that's on the two options that that I showed. I just want to get the right number. I think it was 500 and
Yeah. It sounds about right.
yeah, 594 is the dollars that you would lose, and you wouldn't put up any additional dollars, but then you'd lose the coverage for the people that didn't get the enhanced match. Yep.
I think we'd actually lose more because we have to reauthorize it next year. So we can't wait till 2020 to calculate the loss. We have to calculate it from January 1st of 2019 going forward. So I guess it depends which fiscal year, but I think it's a bigger loss than that because we will be out if we don't reauthorize it next year.
This, your slide, right?
Yep. No.
Well,
Well, the next one has the dollars. That's the people. I think it's the next one. Maybe it's the one before.
I know the buttons are tricky, right?
Yeah,
The arrows
there
are
you go.
tricky. Yeah.
In the back?
Is there any index that's been looked at that would?
That'd be more sensible.
Yeah.
You know, we've looked at that. I mean, again, that's an objective characterization. It's really medical CPI is just a strange bird. We've looked at national health expenditures and whether that's a better indicator. It's hard to know. I think theoretically, if you look at sort of what goes into national health expenditures, it measures the cost in health expenditures broadly. It's not for Medicaid specific, but it's probably more sensible than in just consumer out-of-pocket. Some years it's higher than medical CPI, some years it's lower. Also has, so it's not inevitably one better or another. I mean, the weird thing about medical CPI is if it's measuring consumer out-of-pocket spending, recently consumer out-of-pocket spending has grown because as deductibles and copays in commercial coverage has grown. But the other disadvantage of a disadvantage of NHEI said that the medical CPI you only know 1 month, and it was a 1 month land. There's like a year lag in the NHE, so it's even a greater lag.
Yvonne, Lucy.
Oh, sorry, go ahead.
So, what does the negotiation between the state and CMS look like when you're one of 50 states and everyone's got to convert over and everyone's dealing with waivers and different spends and different, trying to figure out the best trend? What does that look like for states if this were to happen? I mean, is it straight up they're going to just tell the state what exactly they have to spend? Is there going to be a negotiation?
No, there won't be a negotiation. There will be an incredible mad dash to get data. Now, whether states have the ability to comply, and what if they don't? I don't know what happens. There's nothing in the bill that says, well, if you don't get the data from New Hampshire to be able to set the caps, you come up with a default number. So. But it won't be negotiable because obviously the savings can go away and they're not going to give the executive branch the authority to set the caps except for based on the data. So I think, if the data were there, there'll be a data analysis based on 16 as soon as the bill is passed because that sets the boundaries. There'll be a data and then there'll be a push to get the appropriate data for 19. I'm skeptical whether all states will be able to get it in. And then the cap will be set. But it won't be one-on-one negotiation. Now, off to the side, you can have waiver negotiations and other kind of discussions because the other authorities in the Medicaid program would continue. But the dollars then would all be subject to the cap. So you could still have discussions about renewal of a DSRIP or other kinds of waivers, but within the context of what you could spend without the waiver. And that would be a new measure of budget neutrality.
Matt with the Citizen Health Initiative, and I was wondering, something that we're talking about is potentially that we would need to create a high-risk pool. If we could no longer maintain that standard of care and we had to start removing things like pregnancy coverage, what's the sort of level of effort if New Hampshire said we cannot maintain this, we must create a high-risk pool to gain access to that funds, for the state to do that?
So New Hampshire has recently reanimated the entity that was its high risk pool. It's called ironically it's called NHHP, New Hampshire Health Plan. And so the mechanism was actually reinvigorated to produce the assessment on the commercial health insurance carriers for part of the non-federal share for the expansion population cost. So the mechanism is there, and Mike Dayton and John Hastings and the rest of the guys at Helms and Company are consummate professionals. I'm sure that they would be able to put it back together. But I say that not being on the commercial insurance side, not knowing what all goes into all of the development of whatever assessment they have to do to adequately fund that, and for whom and for how long. I think it also depends on the context, right? What else is available? What isn't available? What are we trying to backfill? Yeah.
Steve?
I want to go back to the question that Jeannie asked, which is, how does a state like New Hampshire, we've already, talked about, sort of the dramatically low reimbursement rates. You've got folks around here who would, argue that, we have an underfunded program to begin with. Hospitals are get the lowest of any state in the country. How on earth do we take, several $100 million out of the Medicaid stream and not dramatically slash what it is we're able to do? And as somebody who represents, hospitals, we're going to be the ones who are left holding the bag when all those people who are no longer getting services for any variety of issues fall through the cracks, and where do they end up? They end up at the hospital emergency room at an institution that's going to be less and less able to serve all of those different needs. How does a state like New Hampshire or any state make this work? And I don't ask that in a partisan way. I just, how does the math add up?
You get to answer that one.
What she said before. Obviously you're all gonna have to, if it comes to pass, think about things very differently. I mean, one would hope that the kinds of dialogue that you all had today and efforts that are underway today would continue, but I don't think anyone believes that that would produce the kind of savings that you'd need in the short term to even closely make up that loss. But you all are better experts than I on thinking about what the likely New Hampshire or possible New Hampshire reaction might be.
We're getting close to the ending time, and I was thinking about sort of what's our next step. So I'm thinking about just sort of fact-based messaging for the provider community, for public officials, for the governor, for the public. Healthcare is a human enterprise, and this is all about us taking care of patients. So it seems to me we have an opportunity to message about what could happen, sort of scenario planning about what could happen, so that we can help influence not only in terms of the congressional delegation, that piece of it, but what the governor will and the legislature will want to make a decision on. So if we have any opportunity collectively, sort of geeks to providers, I think we have an opportunity to work together to really make sure that we're explaining this in a way that the public understands it, that the stakeholders understand it, that the governor will understand it, because it seems like it could get lost so easy in the conversation about just sort of healthcare reform. So I guess I would take that as hopefully as a charge for all of us to collectively come together to really think about what might this mean, and how can we provide data and information that people can understand it, so that we can mitigate some of the risks that we're worried about.
And Cindy, if I could turn that into a little bit of a question that I asked you last night. You've heard today about our kind of collaborative spirit and our get it done culture in New Hampshire today. What advice would you give us? Last night I asked you, how do we maintain and build on all of the systems transformation work that's on the ground. It may be in pockets yet to scale. How do we continue to focus on that going forward? And then to Deb, what supports do you need to, keep the forward momentum?
Everything you're all talking about today, and which reflects what you're all, so many of you are working on, is to the end of trying to improve care and reduce costs, right? And so it does seem to me that the efforts that you're embarking on are very much in line with the right direction to be going. Regardless of what happens at the federal level, and but certainly not excluded by what happens at the federal level. There's nothing I see in the bill that other than the funding that should redirect your efforts. So I think that all continues to make sense, perhaps even with greater urgency, but I don't think anybody's projecting the kinds of savings that might have to come to pass as early as, you might not see savings needed from the cap in 2020. It's hard to know. It really depends on the data and what your spending is in the base year. There will be reductions coming at some point. Exactly when they come will depend on the details of the bill and all the factors that we just talked about and your actual baseline and your capped payments. And then it goes to all the other tools that you've all been discussing as to what you might need to look at.
I would say that what New Hampshire Medicaid needs is to continue for all of our stakeholders who are here today to remain active and participating in this process. We have to move forward regardless of what is currently happening, and I don't have a crystal ball, and so that's what I would say is we have to remain engaged and we have to keep moving forward because we know what our priorities are and why we need to get there, and so we need to keep trying to get there.
Great.
The one additional thing which I think goes to your point about the messaging and whatever, there is this myth that exists that states and stakeholders in the Medicaid program don't think about and worry about costs. That there's an open-ended spigot at the federal treasury, and you just keep pulling down money, and you're and it is. One witnesses the conversation today and all the work that's going on, and that is clearly not the way both states budget, and we all work. So I do think it's important to, to the extent that you're talking and thinking about the messaging is to make it clear the kinds of initiatives that are underway and that you all value and think are important. It's not like, is the decision, do you have caps or does Medicaid have status quo, right? There's an incredible amount of change going on in the Medicaid program in New Hampshire over the past several years, and much more on the way. So I think that really is part of the message that's not well understood.
Great. The energy is so low right now. It's like I don't know what to do with it. Can we thank Cindy, because this was amazing information that we got today, and Deb also.